From the Journal of Nuclear Cardiology, this is JNC Cardio Connect, linking experts, insights, and innovations in nuclear cardiology. Let's dive into the next episode.
Welcome to our new episode of JNC Cardio Connect. I am Marcelo Di Carli, Editor-in-Chief of JNC, and today I have the pleasure to be joined by Dr. Paco Bravo, who is Assistant Professor of Radiology and Medicine at University of Pennsylvania and the Director of Nuclear Cardiology at the same institution. With us today is also Dr. Chaitanya Rojulpot, who prior to his current position, he was a research fellow under Dr. Bravo at University of Pennsylvania, and now he is completing his general cardiology training at St. Louis University. Also with us is Dr. Sanjay Divakaran, who is Associate Editor of the Journal of Nuclear Cardiology. Welcome to all three of you, and thank you very much for your time. You know, this paper piqued our interest because we are very keen in helping develop best practice for the field of nuclear cardiology, and inflammation imaging is a relatively newcomer into our field, and there are many things that we still don't know, especially how to use imaging to monitor response to therapy. So your paper piqued our curiosity because of that. And so, Paco, would you mind giving us a little bit of a summary of the motivation behind this investigation?
Thank you, Dr. Di Carli, for the invitation. As you mentioned, inflammation imaging is not something new, but compared to myocardial perfusion imaging, we've been doing this procedure for less than 10 years. But the volume of these procedures have been increasing exponentially, not just at our institution, but across the US and the world. And something that we identify is the large heterogeneity in practice in use of FDG PET imaging for diagnosis and treatment management. In the past, we investigated whether there were any differences in the prednisone dose for assessing treatment response and whether low dose, moderate dose, or higher dose make a difference in the assessment of treatment response using FDG PET. And we observed that patients who were treated with a moderate dose had similar rates of treatment response than patients who had higher dose, but better than those who had a lower dose. The next question that we had was whether there was a difference in the treatment response rate in those patients who were still on the moderate dose in terms of timing, because over the years, we noticed that there was a large variation in how clinicians were actually managing these patients. Some clinicians were actually doing follow-up after a year. Some clinicians were doing follow-up after 3 years of treatment initiation. And so we were very interested in learning whether the timing for reassessment of inflammation after treatment initiation play a big role in treatment response and potentially even outcomes. Our hypothesis was that treatment response was going to be probably similar regardless of the timing, and that would also lead to lower cumulative dose of prednisone, as we know that can lead to adverse events as well.
Thank you, Paco. Chaitanya, why don't you give us a concise summary of the methodology that you used for the study and what were the main results?
Yes, thank you, Dr. Di Carli and Dr. Divakaran for having us today on the podcast. For the study, we had 81 patients that we included from a sarcoid registry that we built at Penn. Those 81 patients had to meet a very specific criteria to do a very clean analysis to be able to answer this question. So all of those patients were treatment naive at the time of their baseline FDG PET scan. So they did not get any immunosuppressive therapy for at least 2 years prior to the first scan. Number two, they had to have a diagnostic PET scan at baseline and a diagnostic follow-up PET scan. And three, like Dr. Bravo said, they had to have 30 to 40 milligrams of prednisone only. And they had a very similar baseline comorbidity status between the two groups. So with that cohort, We assess treatment response as complete, partial, no response by assessing quantitatively the total glycolytic activity at their follow-up scan. And then we also documented taper rate because with prednisone, one of the big thing is how fast should we taper. We looked at cardiovascular outcomes, mainly ventricular arrhythmias, at 1 year. With that inclusion criteria, patient cohort, and methodology, the main findings were one, when we broke up the groups into 3 tertiles of follow-up time, 3 months, about 6 months, or more than 6 months, there was no difference in treatment response between the 3 groups. Number 2, there was no difference in adverse cardiac events of ventricular arrhythmias between these 3 groups at their 1-year follow-up. 3, interestingly, the cumulative dose was also similar amongst the 3 groups. And lastly, the taper rate was also similar between the 3 timing groups.
Super, very intriguing. Paco, what do you think this means? Is this the definitive evidence for people listening? Are we ready to make a recommendation that early is the same as doing it late? What about if they're on different immunosuppressive regimens other than prednisone? The same rules apply?
Yes, thank you. Yeah, so at the moment, most patients are started on prednisone, but there's also a movement towards actually adding a steroid-sparing agent along with prednisone at the time. So I expect that the treatment response is going to be similar, but we haven't really investigated that systematically. But since most patients are started on prednisone, I think these results are going to be applicable. And if they are started on a prednisone dose of 30 or 40 milligrams plus another agent, so I don't expect any differences in treatment response rates for those individuals. So based on our results, we have been recommending our providers to try to reassess at 3 months because we're not seeing any differences in the efficacy of the treatment. So the treatment response rates are similar between different timing groups. And also, we're not seeing that patients who are imaged earlier had worse outcomes. Something that is pending for us to investigate further is whether the rate of relapse is any different down the road. That's something that is pending and that we want to investigate more. But the other thing that was very interesting, and it was not part of our hypothesis, I thought that patients who had earlier follow-up imaging were going to have lower cumulative dose of prednisone. And in fact, they do. But after a year of follow-up, the cumulative dose of prednisone was actually comparable between the 3 groups, which means that they were not actually receiving less prednisone dose towards the end of the follow-up.
And one follow-up question on that is, for people who are followed up early, say within 3 months, what would be the recommended next follow-up if the inflammatory response is not completely abated?
So that's a good question. And I don't think I can fully answer this question because I don't have the data with me, but I can tell you that in the last couple of years, these patients who have achieved partial response after 3 months come back usually after another 3 months. And that may be one of the reasons they continued on prednisone, because it really takes probably a good year or so for clinicians to actually taper prednisone completely once they achieve complete response. In fact, we don't really know whether that's the right approach. If the patients have to remain on low dose prednisone or another prednisone sparing agent, or be weaned off completely.
Great. Sanjay, you were the associate editor for this paper. You're also a practicing cardiologist who sees many of these patients. What struck you about this paper? And also, what did you find as strengths of this investigation? And what are the things that you think we still need to find out? What might be the best practice for nuclear cardiology in this particular area?
Well, Marcelo, thank you very much for the invitation to Cardio Connect, and an equal thanks to Paco and Chaitanya for their terrific investigative work and also for submitting this work to JNC. This is a really important investigative work for multiple reasons. One is it really highlights the significant practice variation that exists when it comes to both steroid dosing, taper regimens, and follow-up imaging. There are published data that show that between single center reports and expert consensus, that there are ranges from 6 weeks up to 6 months or even longer, as Paco points out. But even at a center of excellence like Penn, there's variation between physicians. And it's no different at our center at the Brigham, where we have variation amongst sarcoidosis experts. So highlighting that in a published piece is incredibly important. The second thing I would say is I do think that the work supports this notion that we can image earlier than we currently do on average. But Marcelo, you bring up, I think, the key next follow-up question, which is what is the cadence for the next imaging after that, right? Anytime we see partial response or complete response, I'm always thinking about when is the next time I want to image to make sure that I didn't taper too quickly or I haven't followed this person as closely as I should before they come back with ventricular tachycardia or clinical heart failure. And I think one of the most interesting findings is that the 1-year sustained ventricular arrhythmia rates did not differ based on when the patient underwent follow-up imaging. And this is one of the conundrums we face in caring for patients with cardiac sarcoidosis, which is we worry about inflammation and we treat it, but we worry about scar and inflammation and worsening of either one that can lead to ventricular arrhythmias. So it really highlights that although we're very happy to see a response to immunosuppressive therapy, we should keep our guard up and follow these patients very carefully when it comes to arrhythmic risk and follow-up. And I often tell my patients that I sleep a little bit better knowing that they have a defibrillator in place, not only if to receive a therapy if they need it, but also that we're essentially monitoring them in follow-up, particularly when we taper immunosuppressive doses.
Great. We're almost at time now, and I think you have really highlighted the progress that has been made in the management of these challenging problems with inflammatory cardiomyopathies. But also you outline very precisely what might be the road ahead in terms of what other pieces of investigation we still need to focus on. I encourage all of you leaders in this field to build national registries for this because we really need larger numbers to really understand how to use imaging in the management of these patients. So with that, Paco and Chaitanya, I really appreciate, again, your time today. We are really excited to publish your work. It's highlighted not only as a Cardio Connect paper, but as a leading paper in the journal. And we really appreciate your submission of your work to JNC. I thank the three of you very much for your time today.